life, some of the concepts are lost, okay? For example, perfusion, deep, hard, and fast. I have one cardiologist specific critical care down in the Denver Common that's having his therapist and his practitioners do CPR at 200 compressions per minute. Now, 200 compressions per minute, how fast is a VTAC rate, for example? About 200 compressions a minute, right? Now, how I usually tell my nursing staff, VTAC, picture those very large, wide, peaked complexes, okay? Now, close your eyes, go upstairs to your bathroom and flush your toilet. Flush your toilet 200 more times in a row. Now, the concept there is first flush, maybe the second flush, debris went down in the bowl. But flush 3 through 200, how much pressure does the tank have in order to gain an ejection fraction out of it? Simple basic concepts. Now, the basic concepts, vasoconstrict, prime the pump, apply your tentacles, apply your electrodes. Okay? Now, the concepts have changed. ABC is now CAB. You guys heard that? Hands-only approach to CPR. Okay? Now, the hands-only approach to CPR, try telling an old salty RT that A and B is no longer the most important aspect of my job. So I was a challenger, and I wrote letters, and I wasn't a huge proponent of this. Then I got a letter back from one of the big guys that said, why don't you validate this and call me back when you're done? That's always a nice phone call to get. Now, what finally happened is about 2 o'clock in the morning, we had 4 or 5 RTs standing around, and we did mild chest compressions, meaning we moved the chest maybe a half an inch. Not enough to hurt, but just enough primarily to flex the sternum, essentially. Now, when that occurred, one of the first notable things we found is there is a tremendous amount of ventilation occurring. Now, the negative inspiratory principle, diaphragm pulls down, gate valve opens, air rushes in. A lot of sciencey stuff happened there, but the bottom line is the atmospheric pressure is -2 to -4. And the first time you guys pick up an ambulance bag and you're positive pressurizing the intrathoracic cavity, you're bagging this patient at +20 to +40 above atmosphere. 20 to 50 times what the human body is accustomed to. Okay? Now, every positive pressure breath you give to your patient, dynamically, you're making them worse. During the intra-resuscitative process, one of the most important things is CPR is not a repressurization, okay? One of the biggest misconceptions is it's just repressurization. Repressurized cardiovascular system won't have action. Well, something will happen. Now, primarily it's a nutrition problem. Your potassiums, your sodiums, your calciums, your oxygen, et cetera, all have to build up, convert to electricity, power up the FAM, okay? Now, being a nutrition problem, how do we get the nutrition back? For example, sir, what's your name? Roy. Roy. All of you guys are probably going to die once or twice tonight. Roy here dies, goes into an asystolic arrest. Right? Currently, where are all those important nutrients required for his heart to fire cyclically? They're no longer contained in the heart. They're not throughout the entire human systemic periphery. Right? Now, we can't roll him up like a toothpaste tube, get those nutrients back to the pump. How do we do that? Blood flow. Blood flow, circulation. Now, he's not circulating himself. We're going to have to circulate for him, right? Now, circulation there, all it is chest compression. Your external pacer located on the end of your arm, right? Now, once we prime the pump, we can vasoconstrict and shove all those nutrients back up to the trunk. Now the heart can reach out into a puddle and take whatever it needs. Now, the entire goal of defibrillation is what? It's not jump-starting the human body. A lot of nursing staff is kind of under the impression that it's a jump-start. Battery-to-battery contact. We're going to jump-start the human body. As we know, it's not jump-starting. We're causing the myocardium to overload, reset, and reboot. If we've done our job during the reboot process, if all the nutrients are located in the heart may want to fire cyclically on its own. Okay? So the simple concepts. Now, the simple concepts of BLS, what I teach is BLS is what ACLS is. Okay? The only difference is we add a few drugs, add a few chemicals, add some electricity. Now, BLS being the most important part of the concept, over in England, they have a double-blind study. Over here, we have the FDA. Okay? FDA helps keep our hands cuffed unless our patients decide to go herbal, holistic, or some other old wives' remedy. Right? Over in England, they don't have the FDA. So what they have over there is a double-blind study. Physician dies, paramedic has 1 of 3 envelopes to choose from. Envelope number 1, CPR only. When I say CPR only, I mean CPR with electrics. Okay? Envelope number 2, CPR with amiodarone. Bearing in mind, VFib is our 70% killer. Outside clinic, 7% survival rate. Envelope number 3, CPR with the American ACLS cord drugs. In Europe, what's having the highest efficiency of bringing these patients back?
Number 3.
CPR with the American ACLS cord drugs? Okay? CPR with amiodarone is number 1. VFib is our 70% killer worldwide. CPR only is number 2. CPR with the American ACLS cord drugs is a distant number 3. Okay? These we have here were never designed for the human body to metabolize. We designed them for the human body to metabolize. For example, what does epinephrine do? Vasoconstricts. What else? Inotropic, chronotropic. Helps with the automaticity. What is the bad thing that it does? Increases electrical instability. Increases overload, overworking the heart. You're dumping adrenaline into the heart, right? It hugely increases myocardial oxygen consumption. Now, if we put this into perspective now, how many times do you guys see epinephrine used on these rescue cards? Every single one of them, with the exception of ACS and stroke, right? Just to give you an FYI, the new cards aren't out yet, but epinephrine has now lost vogue. Okay? Let's put this into perspective. Now, physicians have been using epinephrine for how long? 65 years. All right? The last couple of times you've gone through the changes, you may substitute first or second dose of vasopressin. Right? Now, if we put this into perspective, I have an acute anterior inferior wall MI right here on the spot. Okay? Now, what's the most important thing to feed my heart right now? Oxygen. Okay? Now, that being said, this AI-MI throws me into a VFib arrest. And again, how many times do you see epi for VFib? So now, over the course of the next, 20, 30, 45 minutes, every 3 to 5 minutes, you're going to give my heart something that's going to overwork it, overload it, steal all the oxygen out of it. Okay? Now, I have a $half chunk of dead tissue on the face of my heart. So at this point, what the new guideline says is epinephrine, you must define whether she went down from a cardiac event or a non-cardiac event. However, if she's in a VFib arrest, what kind of a historian is she going to be? Right? Okay? Now, the thing is, we know that epinephrine's been causing MIs. We know that we increase the likelihood of making the MI worse with the epinephrine. So that's what the bottom line is. Now, what does vasopressin do? Same thing. It's an acute peripheral vascular vasoconstrictive agent. Okay? There's rolling him up like a toothpaste tube. Once you give him the vasopressin, picture your distal diabetic vessel. It squishes all the nutrients back up to the trunk. Okay? Now, vasopressin, automaticity, inotropic, chronotropic, huge vasoconstrictive agent, but it doesn't overload the heart, it doesn't overwork the heart, it doesn't steal any oxygen out of the heart. Okay? I'm not allowed to be a proponent for any specific chemical, drug, or technique up here, but if I die up here on stage, I prefer vasopressin. Okay? Whew. Now, BLS, amiodarone, and BLS is having the highest efficiency. As long as these compressions are full and effective. How long have you been a doc? Long enough. Yeah. Okay? When's the last time you actually did compressions on a patient in the hospital? When's the last time I did compressions on a patient in the hospital? Sir? Back to back? Well, right? Yeah. Now, here's the thing. BLS being the most important part of the process, who do we assign that role to? Maybe. If we're in clinic, EMS students, respiratory students, nursing students, residents, patient care techs, medical assistants, and who monitors it? Occasionally you have a resident come up, 2 fingers on the femoral artery, hey, good job, strong work, then walks away. Okay? Fantastic. What's occurring there? Okay? Because what's occurring there is if your compressor isn't effective. Now, one of the things that really irritates me is, for example, we have a desk here in the facility, okay? I taught you guys basic concepts, BLS tonight, so I know compressors are being full and effective. However, one of the things that I see is they come rolling into the ER, and Johnny May brings them in doing compressions like this. Who's the biggest guy in here? Scott, pull that on my hand, 1.5 to 2 inches. Could you? Hard, pull hard. Can you do compressions like this? Is that possible to do compressions like this? So who's Johnny May taking care of? Grandpa Zed? Grandpa Zed's going to die, right? So we have a death here, we have a lethal event here, we save them here, turf them out to the ER. ER saves them because I taught the ER out here too. But this process right here happened probably the entire time they left from here up to the hospital. Then they get out of the rig, on the pram, down into major med, compression's being done like this. Coarse VFib, now a fine VFib. Okay? Now, we save them in the ER and turf them out to the ICU, where over the course of the next 3 months, this patient's going to die slowly anyway. They're spending all their finances, selling the house, all their psycho-emotional energy, one organ at a time, because this failed. Okay? It takes about 45 to 90 seconds to diminish the amount of electrical energy that the human body can produce. So death becomes refractory after about 1.5 minutes. Okay? Now, the 1.5 minutes, BLS, the BLS process is what's going to help this patient. More than anything else, more than any sort of electrics, more than any chemical that we use. Now, BLS process, talk about the BLS process. We used to find the xiphoid process. Am I talking too fast for anybody? Okay, good. I'm trying to convey a huge volume in a very short amount of time for you guys, okay? Xiphoid process. Good. Xiphoid process, then move up finger's breadth. Now we're telling you find the center of the sternum. The center of the sternum, radiograph profile, looks like this. Okay? Center of the sternum is where the sternum is at its thickest point. The two ribs connecting to the center of the sternum, the two thickest ribs in the chest, connectivity tissue, most pliable, most malleable. Almost as though God built us in a CPR button right in the center of our chest. Okay? Now the second thing, the depth. Do you guys remember 1.5 to 2 inches? Okay? 1.5 to 2 inches might be fine for these guys right here. What's 1.5 to 2 inches going to do for our trunk? What about your big 24-inch barrel-chested COPD here? What's 1.5 to 2 inches going to do for that? Because 1.5 to 2 inches is here, and my myocardial structure is here, right? So 1.5 to 2 inches has now been changed across the board, 1/3 to 1/2 the depth, okay? 1/3 to 1/2 the depth. Now, proportionally, if you push on the doc's chest here 2 inches, roughly you'll be about 1/3 to 1/2 the depth. Make sense? Well, we hope. Now that you stand up, I kind of stand corrected there. Okay, because the concept is, though, if you push on my chest or doc's chest 2 inches, what are you doing to my heart? It's a multi-chambered hydraulic pump that sits in the posterior aspect of the left chest, okay? Pushing in 2 inches on my chest, I hope you're getting something. And occasionally when that resident comes up and puts 2 fingers on my femoral artery, hopefully he's actually getting perfusion, okay? So 1/3 to 1/2 the depth, center of the sternum. Something about center of the sternum. Center of the sternum, all the literature says mid-nipple line, okay? Find the center of your sternum, because my mid-nipple line is here, and that comes out to my xiphoid process, okay? Now, mid-nipple line, what I find is I find my practitioners, some of my nursing staff. I'm going to say something. Push it up there. Gravity makes dependence. Well, inherently that concept is not gravity makes dependence, okay? Because what I do in fact find, even though it's funny, humorous to say, is I find practitioners doing literal chest compressions at the mid-nipple line, okay? Now, some of these practitioners are practitioners I've worked with for over a decade. But they're taking the authoritative rule right straight out of that book, okay? We're looking for the outward bow of the center of the sternum, where the sternum is at its thickest point. Here's mine, okay? So, center of the sternum, 1/3 to 1/2 the depth. Now, do you guys remember 15 to 2? Now 30 to 2. What we found out is we don't start developing pulsatile pressure until after the 13th compression. So what would happen? We would just prime that pump, we would just get the nutrients back up to the heart, prepare to innovate. Okay? Prepare to innovate. How long can innovation take? I've done hundreds of them. Some of them are brutal. A huge, thick anterior neck, that can take upwards of 90 seconds, maybe a minute. Now, the whole entire time that's occurring, that heart's sitting in the chest, completely deflating. Now, about 2 years ago, I had the wonderful opportunity of being part of a donor procedure. Okay? They don't call it a donor procedure. I think it's not even a harvest anymore. It's something else. It's a recovery, I believe is what it is. Now, the cool thing about this is I got to stand in as first assist with the regional director for Donor Alliance. I've been to lots of ORs, lots of traumas, lots of cabins, lots of surgeries. There was nothing like a full harvest below heart. We had this young lady split stem to sternum, crotch to notch. One of the most notable things what I saw was how full and how robust the heart looked in its natural state. Okay? Now, I was the lucky one. Please remember, first do no harm. This traveled with me for a couple of weeks. I was the lucky one that got to wrap my hand around her heart, clip the aortic structure, and accelerate her. Now, as soon as I did that, the heart knew it. The heart knew it immediately. Now, another thing that was kind of convoluted about was there was no steady degradation of volume and pressure. Once I clipped the aortic structure, there was a vast and immediate deflation of the heart, immediately. Okay? Now, the second thing was I got to feel sinus tach, SVT, VTach, and coarse V-fib. Now, for 25 years, to me, this is coarse V-fib. We used to treat coarse V-fib back in the 20s with the lamp. The seizure in the heart, okay? This is not V-fib. This is V-fib. You guys, the example I use, cardiology tells me it's like feeling a brown paper bag full of earthworms. I have to completely agree. Now, with this kind of action right here, what's the perfusion factor? None. Unless somebody sits your patient up and gravity has some sort of effect.
So how does doing 30 compressions prime the pump?
I don't follow you.
Well, typically, in order to prime the pump, you got to get the venous return back. return. I'm not sure
Right.
me doing chest compressions is necessarily gonna get all that blood from the venous return back into.
It's not, but what you're doing is you're creating hard vacuum at the bottom of the heart. When you do the downstroke, you squeeze all the blood out of the heart. It's about 110 torr, okay? On the upstroke, it creates negative 80 torr to the bottom of the heart, creating a vacuum, pulling over the heart.
Gotcha.
Make sense?
Yep.
Okay. Now, that being said, target heart rate, like I said, 100 compressions a minute. Now, gosh, where was that? Sorry. The BLS principle. Now, the BLS principle, the center of the sternum. The reason why we've moved it to the center of the sternum now is because of the ventilation principle. Now, can I get a volunteer? What do you guys want to volunteer real quick? Sure. Come on. Have you had any chest injuries? Stand right here for me. Right there. Very fine. Okay. I want you to keep your mouth closed and keep your nose open. I don't want you to listen. Listen real hard. Did you guys hear that? Okay. Thanks. Are you surprised how much you're ventilating? Now, I only pushed in on, raise your arm for me real quick. Raise your arm. I pushed in on his chest about this much, so that hurt even a little bit.
No.
Okay? I pushed in on his chest this much. What if I pushed in on his chest this much? Now, that negative inspiratory principle, remember, -2, -4, normal. +20, +40, minimal bagging, just the chest rise. Chest compressions, -5. So dynamically, what's a more stable way for your patient to breathe? Chest compressions, okay? Now, that right there, are you surprised at how much you're ventilating there?
Mm-hmm.
There's a huge amount of ventilation occurring right there. With just that little maneuver right there that you guys saw, over the course of a minute, is enough to keep the practitioner alive. Roughly, it takes about 12 to 14 liters of ventilation to keep me alive. Okay? Now, the male chest, the female chassis, when you compress the female chassis and allow that natural recoil, she's drawing in roughly 200 cc's of oxygenated air. Just hold it in your hand. I'm not going to ask you to memorize it. Okay? Male chassis, roughly about 400 cc's of air. Okay? Now, this big old chest, I did some things in the military. I've got the biggest lungs I've ever seen on a patient. Okay? Biggest lungs ever. 1,200 cc tidal line. The mechanics remain unchanged, though. You push in on my chest, you're drawing in 400 cc's towards that 1,200 cc tidal line. How adequately are you ventilating me? Okay, good. Hold that in your hand. Think about it. You guys are breathing at about 10 to 12 a minute. I'm breathing at about 18 to 24 a minute. If I'm compressing on his chest at 100 compressions a minute, I'm ventilating him at 100 ventilations a minute, as long as my airway's open. Now, if I'm ventilating him at 100 times 400 cc's, that's 40 liters of ventilation. And it takes about 9 to keep him alive. Make sense?
Well, normal tidal line is what, 500 and you're.
Roughly for a minute.
Right.
Right. And that's what we're talking about. Over the minute volume, that 400 cc's times 100 is going to provide him with 3 times the ventilation that he needs. And it's not positive pressure ventilation, so we're not as worried about hyperventilation.
So why do the 2 breaths at all to waste time?
Well, let me tell you this, okay? Let me tell you this. This is a big fungal device. You'll see an RT on this side of the bed bagging to get those darn sats up. Then you have to have a pressor nurse over here with pressor meds trying to drive the pressures up, okay? Because what's happening here is during the intraresuscitative process, I'm introducing a large amount of pressures into the intrathoracic cavity. 50 times, upwards of 50 times what he's used to. Find a vessel on your dorsal hand. Occlude that vessel. Okay, and the heart muscle is a big, huge, striated muscle in the chest. You're not going to squish it entirely. But what about the upper structures of the heart, the upper vessels of the heart? How much pressure does that take? Okay, so ventilation, even just a little bit of positive pressure, introducing the human body works on negative pressure, or arms directly. You introduce positive pressures into a negative pressure system, you're going to have malfunctions. So during the intraresuscitative process, you're squishing all the blood out of the heart, every single breath you make. Okay? So when you ask that question, remember back in the day, back in my day, ACLS, 88 drugs, 45 algorithms, you missed one, see you later, if you get it next time, right? It was all about airway. How fast can we get them intubated? How fast can we put our caustic agents into them? How fast can we apply electricity to them? You guys remember shock, static shock, everyone shock, big shock, little shock, shock? We're walking out of patient's room, right? We're walking out of patient's room shocking 30, 40, 50 times. Okay? You guys ever barbecue and check the meat tenderness with the thumb? What in your thumb? Some of these patients, we're walking out of their rooms, they're done to well done. Okay? 360 160 joules, that's a huge amount of current. So to answer your question, we still need to ventilate. But remember, sweetheart, I need you to grab me an ammo bag.
Okay.